Thank you, Eamon, for your fantastic presentation. Our next speaker is Tim Tyler, coming from New York. You could hear a number of people quote him today throughout different sessions. Yeah.
I think I heard my name mentioned more than my mother in 6th grade. You know?
Tim is a specialist with 25 years experience in physiotherapy and an athletic trainer. And he'll share some thoughts on the screening for groin pain. Thank you.
Thank you so much. A lot of technology up here.
Just as well, I'm not from outside Dublin. They wouldn't understand at all.
Is it working?
Hello, hello. Testing 1, 2. Hello.
Otherwise you can give it yours.
On. This is on. Can you hear me? Yeah. Good to go. Everybody hear me? Good. I'm extremely honored to be here. I'm excited to give this talk. I was totally flattered by being referenced a couple times. I'm flattered to be in the room with people who I look up to, for sure. But I got to be honest with you, I'm really looking forward to sitting in those fancy chairs. All right? So don't stick around and ask a question, because I got to sit in that chair. My mom will be so impressed. So screening for groin pain. You already heard my talk. I mean, throughout the day, if you were here today, this talk, I'm just going to tell you stories is what I'm going to do, some anecdotal stories and go over a couple of those things. But I think what I can do best for the clinicians out there, maybe not all the researchers, is sort of put this together clinically. How we think about screening for groin pains with my 3 professional teams that our institute works with. I work with high school teams, 5 high school teams, and I work with 1 college team too. So we're going to use a little bit of the literature. A lot of this stuff has gone over, gone over today. So let me get started. Lost time means lost money. For owners, for players, 1 game out in the NFL season, that's the National Football League, that's the other football, that's in America, that can be $200,000 lost to the owner. Those players play 16 games a year, and they get multi-million-dollar contracts for 16 games. So big money. Groin strains is a top reason why they lose games. I was going to go over sort of the incidents, but that's been done already. Risk factors and screening for risk factors, are they evidence or not? You guys covered that great. Sports, we talked about all the sports. Hey, we didn't talk about swimming. I don't have this in this talk, but swimming, there's a good study out that showed people that do the breaststroke get a higher incidence of groin strain, and no one mentioned that today. So I found something that no one mentioned. Here you go. And then go over new directions on screening, which haven't been touched on, which I think was kind of neat, and maybe give you guys some opportunities to do research in that area. Everybody this morning covered the incidence of groin strain extremely well. No one mentioned American football, but it happens in American football also. Both adductor strains and FAIs. Emory study, one of the best studies out there in ice hockey, 7,000 ice hockey players. But the underlying tone today, okay, was that everybody looks at groin and abdominal injuries all clumped together. Hopefully we'll get more into that as this conference goes along. Because one of the best studies, and I just saw him walk out the door, I wish he was here to hear me speak and praise his study, but he must have had a hot date while he's walking out with 2 other guys, so I don't think so. But anyway, almost 500 soccer players studied. They looked at everything, playing time, lost time, compared men and women, compared games versus practice injuries. Outstanding study. But they also clumped hip and groin injuries together. All right? And if you look at a sort of a schematic of what can go wrong in the pelvis, there's a lot that you see up there that can go wrong in the pelvis. You can have a labral tear, you can have a tear of the posterior wall of the inguinal canal, what we refer to in America as a sports hernia. You can have an adductor strain. The focus of the rest of my talk will be on an adductor strain, whether it be acute or chronic. But as a clinician, you can't start setting up injury prevention programs, and you can't start screening for something I mean, my screening, injury prevention, and rehab is totally different for an adductor strain versus a sports hernia or versus a labral tear in the hip. It's all different. So how can we clump all this together, create prevention programs, and then create rehabilitation programs for this big clump? We can't, is my opinion, and our opinion at our institute, and hopefully we'll get into that a little bit more. But remember one thing too, that overlapping conditions exist. We just had a hockey player in a collision in his third NHL game, and he tore his labrum. He had an adductor longus muscle grade 2, if you will. I don't know if you can grade that. We'll talk about that too, maybe this week. But he had a tear in adductor longus, and he did not have a sports hernia, but we've seen that too, where overlapping conditions exist. How do we deal with them, both in prevention and both in rehabilitation? So, as I said, adductor muscle injury, that's what we'll be talking about today. That's what our area of study was in. And we have to talk about screening for risk factors. If you're Peter Forsberg, you can probably get away with high heels on the ice and not get injured, but I don't recommend it. What we want to talk about are some of these risk factors and screening for them. Playing conditions. I bring up playing conditions because it can be controlled for. Recently, I was with the United States field hockey team, and how does surface change? Did you know they actually wet the surface in field hockey prior to the game? So maybe we should be wetting surfaces, or maybe not. Who knows? Just food for thought. Australian rules football. Dr. Orchard has alluded that greater injury incidence in football played in warmer and dry conditions versus wet conditions. In soccer, indoor versus outdoor soccer, Emory showed us that it doesn't matter if you played indoor soccer or outdoor soccer, and it doesn't matter if you play on turf or on grass. The adductor strain rate is the same. In terms of American football, there's no specific study that looked at adductor strains in American football, but lower extremity injury risk was a little bit higher on artificial turf compared with natural grass. So those are just some sports and how playing surface conditions, because I want to get to my sport, and a really important article in Sports Illustrated. You ever referenced Sports Illustrated before, anybody? No. First time, me too. The importance of ice. And when you talk to the NHL players around the league, what they'll tell you that the hardest ice is in Calgary or Edmonton, and the softest ice is in Tampa Bay or the Florida Panthers or New York, where it's very, very warm because of either the building or the climate that's there. And what they feel is they feel that they get more adductor strains because they have to push off harder in that soft ice to get the same amount of speed and propulsion. But unfortunately, no hard data exists on this. So that's just anecdotal for right now. Footwear choice, there's some data on footwear choice. Unfortunately, there's nothing on adductor strains for footwear choice. We know that Lamson showed a higher incidence of ACL rate injuries when they had the edge cleat versus the non-edge cleat, but I like to see a study in some sort of sport looking at the edge cleat versus the non-edge cleat for adductor strains. There might be something there. In terms of ice hockey, if you're not familiar with ice hockey, we wear 2 skates on each leg, okay? And on each leg we have one blade. One blade has 2 edges, an inside edge and an outside edge. And the depth here from the middle to each edge is a hollow. And you can get a deep hollow or you can get a shallow hollow. Okay, and Emory did a really neat study where they looked at the hollow. They grouped people 1 standard deviation below the average hollow, 0.375 and 1 above. But unfortunately, it was not predictive of injury. So footwear, even in ice hockey, has been looked at for adductor strains. Now, experience. There's a host of studies here that show what these studies actually show is that if you start younger and play younger, you have a more likelihood of getting an adductor strain. But is it really experience? We know that to win one of these right here, you need a blend of veterans and you need a blend of role players and rookies in any sport. Okay? Now, Emory showed us that the veterans get injured 5 times more than the other players. But did they get injured because it's an effect of age, which the not meta-analysis showed that age was not a factor, but maybe it's that the veterans are on the older players who are veterans are on the ice more, giving them increased exposures. So they're getting maybe a higher incidence of adductor strains. Older players maybe just have stiffer, veterans and older players might just have stiffer adductors, or maybe they have a residual weakness from having previous adductor strains. I have to talk about off-season training because right now what goes on in the NFL, the American Football League, we have what's called optional training sessions. And those sessions are supposedly optional. Yeah, right. If you're not there, you hear about it. But no one's looked in the NFL, and this is something that we're recording right now, if off-season training sessions are predictive of future adductor strains. In this nice study here by Chalmers et al., they looked at the relationship between preseason fitness testing and injury in elite junior Australian rules football players, and they found that a faster play and agility score was associated with increased risk of hip, hamstring, and groin injuries. But that's, once again, a clumped-in injury. I don't know what to make of it. Maybe it's similar to the veterans, that the faster players, the better skilled players, are playing more increased exposure possibly. But I thought I was remiss if I did not show that paper there, because what we know with hockey is that, and Dr. Whitaker mentioned it this afternoon very nicely, that if you have greater than 18 off-ice sessions prior to the season starting in September, usually the hockey season ends in about March. If you're lucky, it goes to June because you're playing in the finals. But the players that skate in the off season, they have a 3 times decreased likelihood of getting an adductor strain if they do that. I love to know what happens with soccer. I think soccer is like an all year round sport, and Australian rules football and those sort of sports, if they have an off season where this could be a factor. I'm not sure. We're going to take a look at it in American football, but I would love to see if that's true. It's probably pretty easy to track. By any account, the number one risk factor is previous injury. There's a whole host of studies, which you heard this morning, that if you've had a previous injury, a previous groin strain, you're more susceptible to getting another groin strain. Why is that? Incomplete rehab is one thing that Dr. Whitaker said today. Definitely think that. Maybe there's damaged tissue in there that never remodels, never heals. There's a multitude of factors which we as a group really haven't gotten a good handle on today. But we know that it's definitely the strongest risk factor. Now, everything I talked about so far is stuff we can ask the athlete, okay? What about physical screening for adductor strains? Is there stuff we can do? Yes, there is, because you've heard lecture after lecture today saying what we can do. Range of motion, Arnson decreased hip range of motion, adduction specifically, in soccer players was shown to increase the likelihood of adductor strain, and decreased hip rotation in Australian rules football players was linked to increased adductor strains. Unfortunately, in ice hockey, our data was in accordance with Emery et al., who showed that hip abduction range of motion, so the flexibility of the adductors, and we also looked at the flexibility of hip flexors, did not play a role in predicting who sustains an adductor strain. Was not a factor. Unfortunately, we did not look at hip range of motion, IR or ER. We did not test that. Hopefully someone will go ahead and start testing. Oh, Andrea, yes. Start testing in athletes' hip rotation range of motion. I personally feel it plays a role. So do other clinicians at our institute. And I think that you think about that closed chain and twisting when you're playing soccer, changing directions. Definitely think it plays a role. Definitely think we need to look at that. And Andrew's doing a great job, I heard today. So strength. There's been some studies that show that if you have weakness of your adductors, you're more susceptible to an adductor strain. The study by Emery et al., who did not show that adductor strength was a risk factor. You know what? They just didn't show it. Maybe they showed it because you had 26 NHL ice hockey teams during preseason that they mailed this apparatus to, train people over the phone how to do this squeeze test with this handheld dynamometer. And you heard from Dr. Thorborg that the inter-test reliability is pretty poor when there's multiple tests or multiple teams and not so good training. In contrast, we used, as you heard today, we used the eccentric adductor test there. There's some caveats there which I want to point out to you in a second, but we show that in the uninjured players versus the versus the players who sustained a groin strain, prospectively there was a significantly weaker in the injured players versus the uninjured players with regard to absolute adduction strength. But as you heard again today, thank you, the best predictor of a groin strain in our data was an abduction to adduction, ADD, adduction to abduction strength ratio. We found a relative risk that when players' adductors were 80% weaker than their abductors, there was a 17 times increased risk. But when we went inside the numbers and took a look at each individual player, the players that are their abductors that were uninjured had 95% as strong. So you want to try to get a 1-to-1 ratio there to try to bias your players not to have not to sustain a groin strain. But that might be sport specific, as you heard today. But we don't know yet because the injury data isn't out by Andrea. So, injured players, on average, 78% less than their abductors. In fairness, Dr. Thorber did produce a paper looking at post hoc analysis, looking at this ratio, but that was not prospective in nature. So it's a little mixing apples and oranges there. I'd be remiss if I didn't mention this study. This is a neat study. This study looked at Australian Rules football players, 47 male players, did MRIs pre and post season. Pretty extensive study looking at cross-sectional area of multifidus, psoas, quadratus lumborum, change in trunk as they did a Valsalva maneuver or a transverse abdominis contraction. And what they found was that they found an association between multifidus, muscle size, preseason injury, and suggest a way to identify players at risk with severe hamstring, groin, and thigh injuries. Really neat study, really elegant, showed some great things, definitely establishes a linkage between the torso and the pelvis. But unfortunately, as a clinician, I'm not so sure that I can get all my pro athletes into an MRI and take a look at their cross-sectional area to prevent or screen for adduction strains. I want to spend some time on how we do it. This is the squeeze test, and the squeeze test here, handheld dynamometer. We use this more as a return to play test or preseason screening, not just looking for pain, not actually measuring the number. Has some drawbacks. We're not able to identify the weak side, which you heard today. We can't calculate a ratio because we don't know which side's weak. So how are we going to calculate a ratio if we're getting just an overall adduction total number? And to my knowledge, I saw the paper just then. I didn't know about that paper, but I don't think it's been validated yet. So we prefer this method here, as seen on the right side of the screen. And there's some caveats there. You want to apply the handheld dynamometer above the malleolus. You want to have them push down and resist. Notice, and at first, when you first start doing this, for some of the new clinicians out there, you tend to push into the table, so you're getting higher increased forces. Be careful of that. You really have to have them come off the table. The inner thigh needs to come off, and then perform the break test. This is how we do abduction. Once again, we're careful not to push into the table. The force is given just superior to the lateral malleolus there, and we're able to calculate the absolute force in newtons there for the two muscles, and then create a ratio. This is some new directions. We've been playing around with Aspin's H-test in the clinic and in the training room, looking at athletes. And this is an athlete who did not sustain a groin strain on there. But you can see how he can go back and forth freely, no problem. Just moves freely back and forth. So return to play. Maybe we should be looking at Aspin's H-test in the adductors, because when someone has a groin strain and he's like 2 weeks into his groin strain and he just can't do it. He can't throw that leg out violently because he doesn't have confidence in the leg, and he can't decelerate with the adductors. So more food for thought, trying to give you something different, something new, because everybody gave my talk already. So the last thing, length and state. We've been on this length and state thing in the hamstring. If you saw the AOSSM abstracts this year, we were looking at have a large sample size with 2-year follow-up in hamstrings of getting strong in the lengthened state when the muscle is at its maximum lengthened position, because possibly that's where it's getting injured. Brockett showed us that in some of his work. Well, the same might be true in the adductors. Maybe we should be looking at the adductor muscle group as not as one muscle, but as three muscles, and measuring it. You saw some really nice stuff by Christian there, Dr. Thorborg, measuring it maybe at its three positions, in its lengthened state, its mid-range, and its shortened state, and maybe identifying, is there weakness in one of those spots? Not sure, but I really just wanted to throw some new stuff that you didn't hear today out, and that was maybe one of them. So, take-home message. When screening for groin pain, this is how we do it at our institute. Maybe the older players you want to take a look at. Maybe we should encourage those folks to train off-season. Possibly not wear edge spikes. Who knows? Definitely stretch the hip rotators. There's some evidence there. Increase adduction force and maybe core strength. Some evidence there. Normalize the adduction to AB ratio, certainly in our hockey players, maybe not in other sports, but we'll have to look at other sports and see if there's a relationship in this phenomenon that exists in a sport besides ice hockey. And then maybe possibly, we can reduce the incidence of adductor strains in our athletes. And possibly, just possibly, we can win one of these some days, or one of these, or maybe one of those. Thank you.